Hello, everyone. Welcome to the National Fellow Online Lecture Series. This is a series that has been put on by the Online Educational Subcommittee through AMSSM, Education Committee, and the Fellowship Committee. So just a reminder, we have a meeting every week. Next week's Online Fellow Lecture Series is Evidence-Based Rehab Modalities, and it's going to be given by Josh Gelhart, who's a doctor of physical therapy, moderated by Alberto Oseguera. And again, that'll be at 8:30 on Wednesday, as most of our meetings are. Hopefully you can join in. So I want to let everyone know that the goals of these meetings and talks are really to supplement your home program's educational content. We're hoping to provide the fellows with direct access to educational content and experiences with our most established AMSSM members. And sometimes we have invited guests like next week. And really the goal is to assist in CAQ exam preparation. So we have access to all the expertise that we have throughout AMSSM and not just at your local hospital or program. So the rules of tonight are that we want you to mute your devices so that your microphone's turned off, your video's turned off, and just enjoy the experience and not participate visually or audibly. However, it's really important that if you have any questions that you submit them through the chat function. I will really try to make sure that we address all of those through the Q&A at the end. If something is pertinent and we need to stop during, I will, but otherwise it'll be addressed at the end. And then also at the end of the lecture, there is an evaluation form, and that's very helpful for what we present in future topics. We meet once a month or every couple months to talk about different topics, and we want to make sure that we're being broad and bringing new topics in, but that are relevant to the CAQ and helpful for everyone. So we really want your input. We really want, suggestions of topics, but also for speakers, because the group of us that are together, we only know so many people. And if we can find that, for example, tonight we have a speaker that I happen to know and I happen to invite, and she's an expert on this, but maybe not everyone else knew that. So to be able to get some more input on opportunities for lecturers would be wonderful. There's multiple ways for you to do that. First of all, you can go to amsssm.org, go to the Education tab, and Fellow Online Lecture Series, and then there is a submission form for suggestions. And also, in this QR form, you can click, scan it, and that will take you directly to the form that you can submit. We really appreciate any of your input on that. So I am going to change gears here a little bit to introduce our speaker, who is Dr. Morgan Lee. Overly. So Dr. Morgan and I know each other from the Cleveland Clinic, where we both did our fellowship and work together. She is a physician who is American Board certified in internal medicine, and she is a subspecialty in sports medicine. She was the former team physician for the Cleveland Cavaliers, the Kings, and the USC Trojans. Am I right there? I think so. But she's also the CEO and founder of Lara Morgan Lee, MD. It's a telemedicine practice offering the best-in-class individualized care in exercise and sports medicine, and an STM Enterprise LLC in teaching, coaching, social media. And the company serves to educate by bridging the postpartum care gap to elevate the traditional way medicine is delivered for mothers the same way we care for athletes. So she is someone who is literally taking care of the highest level of athletes, who is bringing her expertise to a population that maybe hasn't been given the best of care in the past. So after completing her internal medicine residency at University Hospital's Case Medical Center, she completed her fellowship at the Cleveland Clinic, and then honored to serve as faculty at Cleveland Clinic, serving the Cavaliers, as I mentioned. She was then recruited to go out to University of USC, University of Southern California, at Keck Medicine. There, she took care of the Kings and the USC Trojans. In 2022, after experience with the lack of healthcare support and peripartum wellness in her own pregnancy, she turned to focus on providing education and empowerment one needs from expecting to years after the baby's born. Her vision for her practice is clear: bridge the gap, revolutionize the way healthcare is delivered for mothers the same way we care for athletes. You can find her on social media at Sports Doctor Morgan, where she is currently sharing her second pregnancy and postpartum experience after having twins, using her platform to educate, motivate, and support you with the best practice guidance. She offers group coaching and one-on-one telemedicine services, and more information can be found on her website, which I have here at sportsdrmorgan.com. I like aspire to be as social media savvy as you, and you just did a really good job. There's tons of great information and resources on this website. So I'm really thrilled to welcome and invite Morgan to take over
Oh,
the screen.
all right. That should be good, I hope, Dr. Goldberg. Thank you so much for that wonderful, wonderful introduction. I am honored to be here. I think AMSSM is amazing. Of course, I have been a member forever and just am loving what they're doing with education, especially for the fellows. And thank you for the kind words about social media. It is a labor of love and not something that comes easy for most things. So I'm working on it. Anyways, to our presentation today, we have so much to cover. As with most of these topics in AMSSM, this could be like a chapter in a book or even longer. So we have some work to do. Exercise and pregnancy is our topic today. And as Dr. Goldberg said, I have these businesses. This is what I do day in and day out, what population I'm trying to serve. And, even in my former practices, being a female in athletics, taking care of high level athletes, I did end up working with a lot of female athletes prior as well. So no true disclosures, but this is what I do, which is why I was brought here. So that's a good thing, not a bad thing. And I'm actually going to change the topic. I actually got this approved, but just so you know, pregnancy and postpartum, we can't do one without the other. There's going to be so many parallels that would be just like totally missed if we didn't include some peripartum, postpartum information. So AMSSM or you guys are going to love me or hate me for this, but hopefully you love me. And the other reason I'm doing it is it's really an underserved population. If you had a low risk pregnancy in the US, you get about 12 to 14 office visits. Postpartum, you get one traditionally, it's 6 weeks. And that's just, ridiculous. We're not going to follow that here. We are going to do so much better in taking care of this population. Now, to, give breath to the gynecologists and OBGYNs out there, they're actually doing an amazing job. It is very hard, just like all aspects of medicine. The ACOG, American College of Gynecology, has actually recommended we change this 6 weeks visit. This is their current paradigm they're working on. The slow thing to come around is going to be how we run our healthcare systems, insurance, et cetera. So I don't have to talk about that in the news lately. We know that those are all challenging things. I take care of moms like athletes. We've said that already tonight, and that's the kind of mindset we're going to bring to this talk. By the end of the talk, I hope you understand more about pregnancy and postpartum, how it works, how it's affected in exercise, what our goals are for these patients, what the recommendations are, and what our limits are, because there is actually so much that is not known, maybe even more than what is known. So this is where I live. This is a 5-minute search on TikTok. And you're going to look at it and think, oh my gosh, but this is where your patients are getting their information. It really is. Whether it's osteoarthritis issues or pregnancy and postpartum exercise, this is where it's at. And these people aren't physicians. These are some physical therapists, which is wonderful, giving, accurate information. A lot of it's just like influencers or fit people or had a baby. And I think it's our job. This is a very critical time in an adult female's life that we could really capture and combat things like misinformation, actually improve their health and wellness so that way they're not seeing us in clinic 5-10 years later with ongoing persistent, pain, weakness, issues. Like this is a very, very important time. And the amount of changes we're going to talk about are just dramatic. There was actually a Reddit study of this type of thing on Reddit, and it said, what do people actually looking for when they look at these kind of things? Number one, they all know exercise is good for them. Every person that's pregnant knows that. Number two, what's off limits? They don't know. And number three, it was information seeking to decide what they can do and what they can't do. And that's where ACOG comes in. And ACOG is the governing body, as I discussed. Their current recommendations are based off of what we talk about for every other patient. WHO and ACSM, 150 minutes, we all know this is something we have abided by, hopefully in guidelines for our practices. And they go on to say that like most pregnant patients can exercise, but talk to their OB. OBs are looking for things like placenta previa. They're looking for things like cardiac disease in the mom, hypertension, ruptured membranes, incompetent cervix, things that are not things that we're likely going to be taking care of. Hopefully those things are being covered elsewhere, but they're things that you should be aware of. The other component of it is, what are we telling them? Really, we're just saying most people can exercise. Only 23% of the patients that they surveyed in this study in 2016 actually were meeting those requirements. And those were just aerobic requirements. Those weren't strength training requirements either. And the strength training components of exercise for pregnant women is actually becoming more and more discussed recently with the ongoing development of things like powerlifting, CrossFit, et cetera, for adult females. Only 11% of the ones in that study are actually doing some sort of weight training in the pregnancy period, which is astounding to me. And as I said in the Reddit study, they know it's good for them. Everybody knows that exercise is good. That's not something we need to teach people, but you can see the documented benefits that have been studied there, lower incidence of the bad things, higher incidence of the usual goal, which is vaginal delivery. And it's also important to know that so far there's been no evidence that it affects the pregnancy in a negative way in regards to duration of pregnancy, birth weight, et cetera. Obviously, there's ongoing research in this area, especially for high-level elite athletes or specific athletes that are doing things like endurance training of a high volume. We have to understand the basic anatomy and physiology, and I'm not going to read this to you. You can read, this is not important to know the exact numbers as sports medicine physicians, but what you need to understand is one, why it matters, and two, that it's changing constantly. Pregnancy is not a static state, especially physiologically or anatomically. Your cardiac output is changing. You can see there dramatically at different stages of the pregnancy. You're also not able to work as hard potentially because of things like your O2 consumption, your decreased pulmonary reserve. You have a baseline respiratory alkalosis. And why this matters is you might not be able to compensate like you do for exercise normally. You can't really interpret your heart rate the way you normally would. And those come into play when we're making recommendations for our athletes, because if we can't interpret our heart rate, we can't tell them to use a heart rate scale to monitor, which is what we used to do for exercise and pregnancy. Now we use perceived exertion based off conversational dyspnea, which is something we'll talk about. But so it matters because it is not static. Everything is changing constantly. It's also a state of really high energy utilization and hypercortisolism. It's insulin resistant because the placenta secretes hormones that makes glucose more bioavailable for the baby, but that can cause problems for your exercising patients as well, as long as they're also, or as well as they need to eat significantly more. Baseline metabolic demands go up so much. It's actually been compared in the past to doing several marathons back to back or an ultra marathon based off metabolic equivalence. So this is like high stuff just at baseline, just to grow the baby, let alone adding in things like CrossFit, adding in things like running. You need so much more just to maintain that. You have to keep that in mind if you're taking care of a patient that is pregnant and exercising. We're all here because of MSK stuff, right? We love this stuff. And basically the same thing goes. It all changes. You have weight gain, the uterus gets big, it puts more weight on the front of the belly, you get a lumbar lordosis, which also means compensatory changes in the neck and spine. Your breast size gets bigger, which adds to the weight pulling you forward. And everything about your ligaments also changes related to hormones, changing how you move. You think your gait cycle changes when you're walking. Imagine how it affects us when you are doing things like running. It's all dramatic and changing, and it's not static, again, throughout pregnancy. We usually blame the ligamentous instability on relaxin. That's what you've heard, or maybe if you know anything about this, that's what you've heard. Relaxin actually peaks pretty early. It peaks around usually 12 to 14 weeks of pregnancy, and then it kind of stays the same, drops a little bit until 40 weeks at delivery. Then it kind of bumps up in that end of that third trimester. The real culprit here is estrogen, and estrogen is remarkable in pregnancy. It goes from very low to very high when you hit giving birth. When the placenta detaches, it takes a nosedive. You can see my little drawing there. It just basically like falls off a cliff. And if you compare that to what it's like in your adult female day-to-day life, I put in a little squiggle here. This is what essentially the level for ovulation, period, menstruation would be. It's about 400 at its peak. At the peak in pregnancy, it is closer to 20,000. That is just dramatic. So you can imagine that estrogen is affecting all of our tissues. All of the estrogen receptors on all of our musculoskeletal that are affected by that are just going bananas. And then at the end, when we're going to go back into postpartum, it just like falls off a cliff. You're going to get more things like falls, trauma, joint pain, stiffness. I've taken care of patients with, patella fractures, et cetera, because they're just unstable when they're moving. Very common. Hardcore things that we absolutely have to avoid in exercise and pregnancy are the things that make you hot from a core body temperature standpoint. In the first trimester, it's been shown to have an effect on neural tube defects if you're exposed to hot, which is why we worry about maternal fever as well. Exercise in itself outside of the hot environment has not been shown to be a problem. We know fever is because of core body temperature, but fever could also be related to infection because usually infection comes from fever. So they say absolute avoidance of hot yoga, hot tub, and sauna, but exercise shouldn't be a problem. Scuba diving for obvious reasons, contact sports, obviously you don't want to get hit. Think about things like skiing and snowboarding. I've had patients that have asked me about that early on in their pregnancy too. And I don't believe it's an ultimatum. I believe we have to have a discussion, because if you tell a runner not to run, if you have runners in your practice right now, you know that's a problem. If you tell someone who snowboards for a living they can't snowboard, that's a big deal to them. But there are absolute contraindications and reasons why that we have to be aware of. I add something new. Yes, every pregnant patient should exercise. And if you've never exercised before, starting in pregnancy is a good thing. So I don't mean just starting exercise, but it's not the time for your runner who usually does 5Ks to decide to train for a marathon. Not a good idea. And then again, there's a lot of questions about heavy weights and running that we're going to get into further as we go on. These are the things I hate. What no longer passes as good advice. This is where I've spent the last several years of my career just like digging deep. Conversational dyspnea we talked about, because you can't control heart rate anymore. You can't understand how heart rate affects things. So we use the Borg scale, perceived exertion instead. Laying on your back used to be an absolute don't do it. Now we know that laying supine for short periods of time for exercise is probably okay, as long as you're not having symptoms. Symptoms would be things that would be compression of the vena cava. So, feeling out of breath, dizzy, lightheaded, having pain, etc. Hard stops just because so many doctors used to say nothing over 10 pounds. Why? We don't have data that supports that. And then the two that bother me most are in quotes there. Keep doing what you were doing before. How on earth is that going to be a thing? Your body is not doing what it was doing before at all. Or listen to your body. Hopefully on my last few slides, you saw that like listening to that noise as an adult who's, been living in your body for so long, it's not helpful advice. Listen to your body. You don't know what your body's doing. As a physician who's trained in this, I barely know what your body's doing. It is a wild ride. Those are not good anymore. Firm red flags to stop exercise. The first one, hopefully the OBs are seeing things like certain cervixes, bleeding issues, placenta previa. You're not doing that. You have a patient coming into your office, you're paying attention to the rest that are on that list. Those are the ones that you're going to say, something is wrong. You need to get evaluated. This is not going well. I love some yellow flags though. Yellow flags are the things that say, maybe we should make some modifications or adjustments. There's not one good or bad exercise in pregnancy. I'm going to say that again because social media is like the one exercise you have to do. No, there's nothing that is good and bad. It has to do with symptom management, knowing what's happening as you're doing the movement and being sure that you're doing things for proper recovery. This is a video of me that I have on social media at 3 weeks postpartum with the twins talking about coning. Pelvic heaviness and pain, poor recovery. I just told you that it was this like hyper cortisol driven state where your body is like doing a ton of things. This is postpartum, by the way. It happens in pregnancy as well. You can see the little pouching there that's happening when I'm sitting forward and breathing. That's coning. It's pressure management of my core. So all of these things are happening at once. I'm trying to breathe, I'm trying to exercise, and this one I'm doing a diaphragmatic breath and correcting it, and it goes away. So if you are having things like pelvic heaviness with exercise, with breath work, if you're having coning, which you just saw, if you're not recovering from exercise, you're having issues with sleep, like these are all signs that as a pregnant patient, you may be doing more than what your body's able to handle, and we might need to make some modifications. I'd also add anything you can't do with proper breath and proper form. If you are someone who does CrossFit, for example, and you like to power clean, at some point the belly's going to get in the way. And maybe no other symptom, but we have to be sure we're doing it properly. And we have to focus on what we're doing for the right reasons and for the long game. Dr. Goldberg said, I had twins. They are 10 months old right now. So I'm still postpartum, fully postpartum. But you got to play the long game. I knew having twins that my body was going to change, but I didn't want to end up having long-term pelvic floor issues. So I'm a runner, but the moment I felt issues with running, I was making adjustments. Now, there's no data that says running is absolute and that you're going to have problems. You'll see that data in a second. But I know personally what my goal was. And then we have to educate patients to focus on the long game. Pregnancy and postpartum is a very long period of time. Doing things that make sure they maintain and grow and change with it is really important. I put multiples in question marks because according to the Canadian studies, they'll say, or excuse me, the Canadian guidelines, they'll say stop at 28 weeks. In theory, in twins, you're usually measuring about 6 weeks ahead. So if you're like 24 weeks, you're measuring 30. So keep that in mind when you're advising these patients on exercise. But I was very lucky. I had an amazing OBGYN. If you're in Chicago, let me know. I can give you his information. He basically said, I had a quote unquote lower risk twin pregnancy, being die-die. And like, he's like, do what you know, and we'll see what happens. There's another big book that's very popular in multiple pregnancies that basically says, like, really do light things only, like this is a big deal. And for some cases it may be, but again, this is me saying you can't just make blanket statements for no reason. I was able to maintain my physical activity, cut back when I needed to. I'm back to running now. I'm having no urinary symptoms. So I know it can be done if it's done in a thoughtful way. I usually advise my patients, first trimester, you may feel sick. That's fine. Do what you can. Second trimester, it's probably your build phase of exercise if you're someone who's familiar with, exercise terminology and physiology. And then third, we're going to do a deload because we are really trying to focus on pelvic floor opening, birth, and then everything that comes after with postpartum, which we're going to talk about in a second. But like there is a long game here that we have to think about, and making sure that we're paying attention to all of this throughout each stage is very, very complicated. And even as someone who knows as much as I do, it's a lot. So these patients need really good advisement. They really, really do. I mentioned the deload in the third trimester. It's not required. This study says you can probably exercise at a vigorous rate in the third trimester and it's not going to cause a problem. We don't know a ton though, so take that with a grain of salt for some degrees. Seems like it's okay, but more studies are ongoing. Injury-wise for exercising in pregnancy, a lot of things that we've talked about already. Back pain is really common for the anatomic changes. Ligamentous issues, we talked about diastasis recti and coning. The diastasis recti is essentially what happens when coning is persistent. The separation of coning is along the linea alba. When that maintains after pregnancy, that's called a diastasis. Diastasis can be trained. We'll talk about that in a second, and they can improve, but it's a very common thing that happens in pregnancy. There was a study in like 2015 that said 100% of people at 35 weeks have some type of diastasis. By 6 months postpartum, that drops dramatically, but not always. There's also carpal tunnel, urinary issues, and issues of the pelvic floor, which are going to be talked about on the next slide. And honestly, they could be a whole talk in themselves. So I'm going to touch on them very briefly. If AMSSM wants me to come back, I can do an hour long on just this stuff because I guarantee you, you've seen it in your practice. You probably didn't know you had. It is so interrelated to hips, to your back, to your core. I just talked about that coning, and let me explain that in a little bit better way. So the pelvic floor, as you can see here, is kind of like the hammock. It's the bottom of a canister. The diaphragm is the top. The front is the core, and the back is your, back. When you take that diaphragmatic breath that I was describing in that video, you're filling up that canister, and then all of those things have to work together in a coordinated fashion. The pelvic floor needs to be strong, but it also needs to be able to relax when you give birth and also in life. And, your 18-year-old athlete that's a volleyball player that is having urinary issues may have a hypertonic pelvic floor because of overactivity, which can lead to a variety of complicated problems. So keep the pelvic floor in mind. It can be a very complicated thing, not just in pregnancy, but absolutely in pregnancy and postpartum. SPD is symphysis pubic dysfunction. It has to do with obviously your pubic symphysis being irritated related to the weight of the belly, the pelvic floor engagement, and the hormones that are floating around. I mentioned at the beginning when everybody was logging on, my husband is an orthopedic trauma surgeon. So he was doing like a pelvic study where you like physically press on like the pelvis. And he was like showing me what he was doing. And I was postpartum and I was like, holy moly, that hurts in my pubic bone. And because even if someone who didn't have SPD, the changes in that area when it's like manipulated is wild. So always keep this in mind with your patients that are pregnant and postpartum. And by postpartum, I mean not months, I mean like years. Like I believe fully the intense phase of postpartum is like at least 18 months long. It's a long time. This was fun. It's in 2016. The IOC came out with some guidelines for pregnancy, or for pregnancy and postpartum in high-level athletes. And it's basically all the things we've ever covered. The one I wanted to allude to a little bit more was the anxiety and mental health. We know from our concussion research and a variety of other things that you take people out of their environment. It's hard for them mental health-wise. Imagine taking people out of their fitness environment or their third home. And then you add a thing like the hormones from your pregnancy, your body physically changing. You're used to being a high-level athlete. Maybe you cannot participate to that level any longer because of these things. Anxiety and mental health are huge in the peripartum phase and something that we absolutely have to be cognizant of as sports medicine providers. VO2 is fun. We talk about that sometimes as well. And, this is just to illustrate that it changes a lot, again, during pregnancy, and your endurance isn't going to be static and your needs aren't going to be static. The one thing that this did point out that I thought was interesting is that at 6 weeks postpartum, they were definitely down, both VO2 max and strength. And that is across the board something I see. You can maintain these things in pregnancy, but the hormone changes and the physical changes and demands of postpartum really do alter our bodies in a significant way. And this is part of that whole like bounce back culture. Like the changes that happen have to take so long and need to be trained properly. And this is why I say treat people like athletes, because it does need to be done like an injury to the body. Delivery itself is a trauma on your body, even if it is the most blissful experience and quote unquote non-traumatic. It's physical trauma happening to your body that needs to be healed properly. This is another illustration of an article. We're not going to go through this, but I wanted to put it in because it essentially talks through everything that we've talked about so far, adding in a little bit more based off some research by week for peripartum athletes, which is really, really interesting. All right, switching gears quickly to postpartum. Did you know that 60% of patients don't attend their postpartum visit, that 1 6 weeks visit? And this would be consistent with what I've seen in my patient population as well. They just don't go because they call it the visit where you go. It's just this arbitrary thing. You're going to get told, okay, sure, you can exercise and have sex. And that's it. That's the guidance they get, which is bananas to me. Because what does that mean? You've seen in this whole talk, everything about pregnancy is changing. At 6 weeks, you're supposed to just magically go exercise? How? How on earth is that realistic? I will tell you firsthand, it is not. Absolutely not. The elements of postpartum care that ACOG recommends are listed there. And for physical recovery from birth, this is their little kind of like peel out from that. This is what they tell the OBGYNs to do, provide actionable guidance. And I love OBGYNs. I work with a ton now. And I believe fully, and they agree with me, we are asking the wrong people to answer this question. OBGYNs, for the most part, and I'm obviously being very general here, don't know musculoskeletal medicine like we do. They don't know exercise. They don't know sport. They don't know the demands on the body. And asking them to give guidance to a runner or anyone, for example, going back to just life, let alone high level sport, is just bonkers to me. We need to be the ones providing that actionable guidance because we understand sport. We understand musculoskeletal medicine at a very high degree. That's what we do. I'm not going to go in and deliver babies, that's for sure. So it's a mutually beneficial thing that we stay in our ranges for sure. Now, I wish that there was more access and that they had more time with their patients so they could do these sort of things. But is like we're all stretched to the limits. And again, back to insurance demands and healthcare is a systemic problem. I don't believe this is an OBGYN problem. This is a systemic healthcare issue, but I would love to be a part of fixing it. Treating moms like athletes, we've alluded to that already. These are the components that I use because all of these things are altered and affected in the peripartum fashion. And it's key that we address all of these. Postpartum physiology, briefly, I've said it was crazy in pregnancy, but could you believe that it's probably even more crazy in postpartum? Immediately after birth, things start changing. That estrogen cliff just like starts a cascade of wildness, but it doesn't happen quickly. You're not like it ends like 48 hours after birth, you're like good to go. It can last months. And if you have a patient coming in with a problem and they're like a few months postpartum, this could be something that you really, really need to know about. And also of note, they are continuing to be prothrombotic. So if you have someone coming in and you're putting them in a boot or a cast or something like that, and they are several weeks postpartum, that's important to remember. Definitely. Hormonally speaking, I talked about estrogen, but that's not the only player here. Oxytocin, progesterone, what have you. Estrogen is important because when it is low as what it is, especially if you're breastfeeding, it can put you in what feels like essentially a perimenopausal state. If you're on social media at all right now, perimenopausal conversations are huge. But it can cause things like night sweats, joint pain, poor performance with exercise, difficulty gaining muscle mass, which again, strength training in postpartum is going to be key. If you're breastfeeding, you can't gain the muscle mass, then maybe going back to something like running isn't ideal until you've had time to get those strength goals assessed. And then when you wean, if you are breastfeeding, it messes with more hormones, of course. Pelvic floor rehab, I believe, should be done for every person that has a pregnancy ever. The incidence of urinary incontinence there, you can see is 15 to 30%. This is hugely impactful on someone's life, and it can be very much improved by pelvic floor rehab. We don't really know for high-level athletes what this means. Is it worse for you because if you're doing Valsalva maneuver, lifting barbells, running, doing impact? We don't really know. There's limited studies and evidence, but I believe we should be proactive. I think, again, every patient should see them, hands down, no questions asked. There's no harm. It can be extremely beneficial. And we have to be able to do more when pelvic rehab stops, which is when I go into my rebuild phase. But quickly before we talk about that, this is the current research that I think is very exciting. We are starting to now do research in high-level athletes, weightlifters, CrossFit. This study, and this is a group that is pretty prolific, that is putting out some really good information in this type of population. And we're saying, is this going to be okay? Like, can this be done? And are they going to have worse problems with things like urinary incontinence, pelvic prolapse? The conclusions of this study were no. Everything seemed to be about equivalent, and there was no change for the patients that were doing this versus weren't. So obviously small, we're not really sure, but this is some really exciting work that is being presented in this population, and I'm really glad we're having this conversation. I wanted to go back to this a little bit. This was when I was talking about the diastasis, and I'm not sure that I explained it well in the beginning. So diastasis can persist postpartum. We talk about the coning in pregnancy. Coning can happen postpartum. Diastasis is a gap in your rectus and deep core. I hate saying that because, again, social media buzzword. But it's a separation. In this video, you'll see me early postpartum with the twins checking. You're kind of measuring with your fingers the gap. And you're looking for muscle tone. You're looking for how it is controlled when you do a breath. And is there a persistent gap there? Now, immediately postpartum, as I said, it's very high. At 35 weeks pregnant, it was decreases to 50% at 4 to 6 weeks postpartum. And then 40% of patients were noted to have it at 6 months. I still have one now, 10 months postpartum. I can connect and correct across it. And in the most persistent way, if you train it well, it should not physically be a problem according to current evidence. And there's really mixed out on whether rehab can improve this, if it's naturally improving or if rehab can add something to it to improve it. But this is really important to me because I actually was just talking to some plastic surgeons and checking because I was like, I have a persistent gap. What is the long-term effects of this? Is this going to be a problem for me? Exercise, life-wise. This is from pregnancy. It's not something that exercise necessarily makes worse or better, as we have studied, but like, what does it mean? This just came out in 2024, and it was kind of eye-opening because I tried to get it approved to see if they would approve a repair for me, and it was denied by insurance saying it was cosmetic only because, like to look like you had a six-pack as opposed to having a gap in the middle if you got your, body fat percentage down. But this study speaks to otherwise. They're saying that, as little as 3 and as many as 30 years later, they're kind of looking to see what happens. And there may be things like weaker ab strength, quality of life, hernias that are still persistent in our pregnant patient population. And I bring this up because you're going to see, again, patients in your office 10 years from their babies. And have you ever once checked to see if they have a persistent diastasis that they can correct or not correct with their breath? Like, I guarantee you, most of you haven't. And as I said in the pelvic floor talk, portion of the talk, core is related to pelvic floor, which is related to hip pain. So someone coming in with hip pain, glute weakness, etc., could really be having issues because they're having weakness in their core. They might have an ongoing diastasis. Do they even know? Do they understand what this stuff is? And it is all interrelated and all wild that this is so not discussed in, obstetrical care. Postpartum care is just not existent for this at all. And then in our world in sports medicine. I mentioned rehab. Rebuilding is everything else. I treat it as a trauma, return to sport. We're going to do it just like we do a return to sport for a traumatic injury. Do we make it back? Yeah, maybe, sure, possibly. Sometimes better, sometimes worse. The data is all over the place for high-level athletes. Do you make it back after childbirth? And to what level do you make better performance or worse? It's really over the map. We don't know. Personally speaking, I think you can do it if you do it properly and do the rehab, rebuild, return to sport type programming that I talked about. Injuries, we've covered most of these. Decoria veins is super common from lifting babies in the postpartum period. We know how to treat that. And then I think the last one is the most important to hit on. If you go back fast, without proper rehab, without proper rebuilding, if your patients are coming into you, they're going to have overuse issues. They're going to have stress fractures. They're going to have, long-term sequela that happen because of the lack of that rebuilding and retraining. And it is key to capture them during that time so they don't come back into you 5, 10 years later, come to my office saying they're having knee pain. And it all unravels back to this. This is kind of where the beginning of the fall starts, for their injury patterns, if you will. And the last thing we're going to touch on just very briefly, I was asked to talk about lactation because our patients that are athletes, if they are breastfeeding, and that can affect their ability to exercise, as well as we can have issues related to exercise from breastfeeding. The sudden estrogen loss, I said, if it is persistent in because they are breastfeeding, that essentially puts you into a perimenopausal feeling state, which is going to affect their ability to exercise, ability to gain muscle mass, well-being, mentally, all of those things. We know from data that exercise in itself has not been shown to limit your breast milk supply. If you're trying to feed on demand and you're doing all the right things from a lactation standpoint, the exercise in itself is not a modality that will cause problems as long as you're keeping your hydration and caloric intake high enough, keeping your empties of your breast to a high level, your magic number that you need them to be, and not, skipping those when you're like running marathons and things like that. It's important to note that breastfeeding in itself has been shown to affect bone mineral density. Because it's leaching calcium from the maternal bone mass. It is related to increased bony injury like stress fracture. So if you're seeing a patient come in and they are several years postpartum, it is okay to ask them if they're still breastfeeding. The American Academy of Pediatrics now recommends up to at least age 2, potentially. Definitely age 1, up to potentially at least age 2. So as that is something that your patients are doing, that's 2 years later. I guarantee you've seen patients 2 years after having a child, and that's not a question that usually comes up, but it should. We want to be sure that we're not missing that. Some little anecdotes. A supported bra is always great. Empty prior to exercise. Don't compress them too long because if you do, you can get a risk of things like mastitis. I love a zip front sports bra for this. You can zip it down, halfway when you're just like walking to go exercise. And when you need to exercise for impact, you zip it up the rest of the way. And that helps control things from a bounce standpoint and uncomfortable standpoint. But then as soon as you're done, you can also release the pressure. So that way, you decrease your risk of things like mastitis. And then the adage is don't change more than one thing at once. So if you want to start an exercise program and you are lactating, you're breastfeeding, don't start your exercise program, go back to work and start a diet all at the same time, because you're changing 3 variables that could very clearly affect your milk supply, and you're not going to go which one or what is happening. So start one thing at a time. If you want patients to go back to exercise, advise them to do that before or after they return to work, not at the exact same time. You want to give it a few weeks in between these changes. And if you need more information about mastitis protocols, treatment, we are, as of 2022, have changed things a little bit. We're doing ice, NSAIDs, and we're feeding per usual. We're not adding more feeds or more empties with a pump. We are not massaging. We are doing lymphatic massage instead. And then there are specific antibiotics that are suggested for things like mastitis and abscess if needed. Abscesses are also often drained if needed, but we try to avoid those if we can by the compression component and emptying before exercise. And with that, we have made it to the end of all of that spiel. So what is our role as sports medicine experts in this? I was clearly saying earlier that OBGYNs are amazing. They have extremely important data and they're keeping you and the baby safe when you're pregnant. Unfortunately, their ability to help postpartum is more limited. Just the way our system is set up, healthcare is broken. We all know this. And I think we have such amazing information. And I have done such a deep dive into this in the last several years of my life, with the twins. It just, I started taking care of women in sports because I'm a female, and that, as you're a female in this call, that often happens. I took care of, males as well, but a lot of females, a lot of runners. I was the team physician for women's basketball at USC. All the volleyball players wanted to see me. And then you have a baby and you see the gap firsthand. And even being as privileged as I am with education, access to rehab. I told you earlier, I'm married to a surgeon that treats pelvises. He's pelvic, so he knows this area. This is all, I'm the most privileged person ever. Going through my first pregnancy was wild. And then going through the twin pregnancy was almost like a little poke at haha, you think you got it figured out the first time? Try to do it now. But I'm proof that it's possible. I have, no urinary symptoms. I'm exercising again. I did it. I made it through. And if you have patients that need help with this, my information's up there. Email me. Find me on social media. Please do a follow. I'm trying to grow that. Whatever you need, I'm here for you. I know this is an area that you don't get covered a lot in fellowship, and I hope that this was very helpful for you so that you can just totally understand it. And if not, you know who to ask when you need, because you're going to have questions, guaranteed. All right. Quickly to the CAQ questions, and then we will see what the chat is and open it up, I believe, for Dr. Goldberg. So question 1. A 31-year-old G2P2 runner presents to your office. She's got right hip and groin pain. She's 11 weeks postpartum. She says she's breastfeeding. On exam, her x-ray is normal. So what are you going to do? The answer is C. You're going to get an MRI. We're obviously looking for a stress fracture here. I was just talking about calcium leaching from the bones. But if you would have not asked her if she was breastfeeding, you would have not asked her if she was postpartum, she may not volunteer that information. So make sure you're paying very close attention to those patients that you're taking care of, because that's really important. You don't want to miss that. Question 2, 27-year-old G1P1 was just diagnosed with gestational diabetes. I told you already, it's her placenta. It's not her, just the placenta. In addition to her nutrition consult and the medications, her OB's got her covered. She's feeling great, but she comes to you and she's scared. What do I do for risk reduction? How do I exercise? What do I do? And we know from the ACOG guidelines that gestational diabetes is improved with C, aerobic exercise, weight training, which they added more recently, as I said, and then monitoring her weight gain, because weight gain in pregnancy is important to monitor, especially in this case. And then the last one, my favorite question, and you'll see why very soon. 40-year-old G2P1 presents 8-week gestation with di twins. She's had 1 prior C-section for persistent breech. She was able to return to her normal level of fitness, running, weight training, Pilates. After her first pregnancy, was feeling great. Only on a prenatal vitamin. She's coming to your office because she is scared to death about what this twin pregnancy is going to mean for her ability to exercise, both in the current state and also long-term. Do we tell her bed rest? Do we say light activity only? You can limit activity maybe after 28 weeks, or nothing over 10 pounds, nothing on your back. This is a twin pregnancy, shut it down, scary. So this one, according to guidelines, it would be B, light activity only. And considering limiting activity after 28 weeks, again, according to the Canadian guidelines, they're a little bit more specific than the US guidelines, which are kind of vague. And then also that book that's something about multiples. I'll put it in the chat if I find it, or I will tell you later if you have questions, ask me. It's the one book for multiples pregnancies. is very, very specific about limiting activity. And yes, there are absolutely indications for that. 100%. Again, die pregnancy. This is me, by the way. That's why I say I'm very fond of this question. This was me. But there are also cases where we can't just do blanket statements anymore. So I would argue the answer may be D. We can do better. We need to do more research. We need to understand these patients better. And as sports medicine experts, musculoskeletal experts, exercise experts, we need to serve this population just as much as we do our professional athletes and everyone else. Soapbox over. And then that.
Morgan, that was excellent. Thank you so much.
Yeah,
I know firsthand that this is a very underserved population. And, you know, sometimes what happens is that we have our own experiences that lead us to learn things or to explore things. And clearly you've experienced that. You know, I experienced it as well as a female sports medicine physician having a pelvic floor issue. I now actually ask questions about urinary incontinence in my runners. I talk about you know, pelvic floor therapy, even in young athletes.
absolutely.
And it's you know, it's a topic that no one wants to talk about. My other favorite topic is just talking about hormones, because I think, you know, we are not, females are not males, and the hormones really play a large role in how our body reacts to stress and recovery. So, you know, as you already mentioned multiple times, we definitely need to continue to look into this.
Yeah.
So there are a couple of questions that I wanted to bring up from the chat, and I also had one question, but first on your questions. So, given the fact that in your first question the person was breastfeeding, and we know that that might leak, you know, pull calcium out from the bones, what makes you jump real quickly to an MRI versus, you know, I think that I extrapolated from what you said that maybe the history suggested stress fracture. But I think a lot of times that patients that are postpartum come in with pelvic pains, pubic symphysis pain, and you know, it's hard to know, like, hey, just back off your activity, maybe do some PT to try and get that back. Like, what makes you jump to an MRI versus trying to wait a little bit?
Yeah, I try to simplify it down as much as possible for the sake of a question stem and time. Obviously, your exam is going to be hugely important here. If you have concerns of, bony pathology on your exam, they're having no other issues as far as, ligamentous stability that you can check. If you're able to kind of do different modalities and get more information, like that's obviously easy to do. And then I think the prevalence, and I actually, when I wrote the question, I made her 11 weeks postpartum on purpose because I was implying as well that she's back to running at 11 weeks postpartum. And while some people potentially could do that and not have issues, unless she has went through a proper rehab program, which shouldn't start until 6 weeks likely, or like, formal rehab usually starts around 6 weeks, to get back to running by 11 weeks, I would be highly concerned that she had ramped up her mileage very quickly. And then if she's breastfeeding, so the nutritional components of breastfeeding, is very high, physiologically demanding. And if you're not very cautious about intake and nutrients and you're ramping up quickly, you maybe don't have the muscular strength, and we know calcium is leaching from the bones. That would leave me, even with an exam that was like, I don't know, maybe something's going on, pretty highly concerned that there could be a bony problem. And in someone like that, I wouldn't want to miss that. Yes, you can still do PT, you could still do reassurance. I would definitely back her off if she's running already and hasn't done a rehab program. But I would be very cautious as to not miss something that could be that traumatic, if you will.
So I love all the things you said, because you're bringing in, you know, increased activity, you know, maybe too quickly, doing a high impact activity, and nutrition. And if you don't ask about nutrition, you're missing the boat. And if you don't ask about how she's dealt with her pregnancy, you're missing the boat. If you don't
Yes.
ask about, are you breastfeeding? Are you feeding yourself? Or are you crazy stressed and you're not taking care of yourself? So yes.
Yeah, I
So
mean,
I
I
just
stopped in my
wanted to
twin
make sure I
pregnancy.
point that out, that there was
Yeah,
probably
yeah,
more to
absolutely.
that then.
Some people will stop running in their pregnancies, stop running at like, when they find out, or, 10 weeks, 12 weeks, whatever it is. And then when they have the baby, they're like, I'm a runner. And it's
Right.
like, whoa, whoa, you haven't ran in a year. Like we gotta kind of, as a runner, this quite well, we gotta kind of build a foundation, and we gotta rein this in. There's specific drills too that I go through with patients as far as runners. If I'm treating them for their return to impact and for their, control of their lower extremities and their trunk, their core has to be engaged. It's so complicated with runners, getting them back in a way that is mindful of their desire to run, but also like cautious to be able to develop. And I always, same thing I tell my male athletes or my high level athletes that I take care of is like, you're going to do this now and you're going to hate it, but I'm going to get you back and you're going to be stronger. You're going to be faster. You're not going to have an injury. Like this is where we're going. This is why. This is the gold. And that's usually helpful.
So, one of our listeners had a question about the safety of running throughout pregnancy. And I'm curious, I'm a runner and I ran throughout my second pregnancy. I could not through my first. Uh, I have clearly heard different opinions about the safety of running, and I'd love to hear your thoughts.
Yeah. Data, simple. We don't really know. Studies on the pelvic floor say maybe, maybe not. As I alluded to in the slides, like impact, running, high Valsalva sports, in theory, you would think would have a higher incidence of things like urinary incontinence, anal incontinence, pelvic floor prolapse, just because of that canister that I talked about. And the pressure has to go somewhere. The impact has to go somewhere. And now I have a very specific, N of 1 study where I could compare a singleton pregnancy to a second twin pregnancy. There is absolutely a difference in the impact I felt on my pelvic floor and in my core and in my body changes from one pregnancy to the next. And they were very different pregnancies. And I say that to elude the fact that every pregnancy is going to be different. And everybody's baseline running status is also going to be different. You are a very high trained, well-established runner. Getting pregnant, running for a longer period of time might feel better than for you than someone who is a couch to 5K on occasion, lighter runner. They might stop sooner. And I really want to stress that there's never going to be a no. You have to think, am I having symptoms? Do I have pelvic floor symptoms? Leaking, pain, pressure, whatever. Do I have core symptoms? Am I able to control my breath? Do I have coning? Am I feeling like I'm just kind of like protruding out, when I run? Am I having hip pain? Am I maintaining my strength? And then what are my goals? If you are an Olympic athlete that's a runner and you need to keep running because this is your game and this is your sport and we want to get you back as quickly as possible, I'm going to advise you differently than if you're a recreational runner that likes to run for exercise. Because although we don't know long-term effects on the pelvic floor, like thinking through this and knowing what I know, it has to do something. Like you're putting like the baby in there, let alone, just like gaining weight in running affects how our bodies feel when we run, right? Like there has to be something going on that we have to be cognizant of and make sure we're monitoring our goals and also making it individual for the patient that is doing the running, because every pregnancy is different. Every runner is different. Goals are different. It's highly, highly variable.
So, I think one of the things that we talk about a lot in general is listen to your body. I have a struggle with that because if you take an adolescent athlete, hopefully they're not pregnant, but if you take an adolescent athlete, you say listen to their body, they might think everything they do hurts, but they're like, I want to be the best basketball player, so I'm just going to keep pushing on. You take somebody, I'm a runner and I got pregnant and I was like, oh, I have pressure in my pelvis. I don't really care because that's because I have a baby there. I'm just going to keep on running. I did not, I listened to my body, but it didn't tell me to stop. It just said, oh, it's not as comfortable.
Yeah.
So I think that is hard advice. And I think that what you have said is, those symptoms of pressure, urinary incontinence, things like that are things that we need to let them know that maybe that's not something you should run through or push through.
Being as specific as possible. I said as well, I don't like the advice of that either, because like you can't even really listen to your body in pregnancy. I had my first child at like 38. My body was telling me things that I had never heard before. Like this was like wild to me. It like felt weird. Like just being pregnant felt weird, let alone pregnant and running. So we need to be as specific as possible for our patients. Make sure we're saying like, not just listen to your body. We're saying, if you have this symptom, it could be a sign of X. We know in the geriatric, let's fast forward, these patients get, 60, 70, whatever, 80. I don't know the specific numbers, but like a large percentage of us as females are going to develop some degree of prolapse. Like that's very common. Most of us end up with prolapse, whether or not you have kids or not. Now, if you have children, vaginal birth, yes, it's probably going to happen too. So like, what can you do to mitigate your risk long-term? How much gains are you getting from running in pregnancy? Now, again, mental health is important. There's definitely things that you can be gaining in running, but can you do it in other ways that may hypothetically, this is me speaking from anecdote, like give you that same benefit, but also potentially decrease things like leakage. Because you have to think, even if you don't have the data, leaking when you're running, bad. Like that's just not, that shouldn't happen. Like that's not
Well,
physiological.
so I would argue that anything that you do, if you activate your pelvic floor, and there is actually a question here about pelvic floor PT, anything that you do that activates your pelvic floor is going to be more beneficial than running and having that pounding. So even if you're doing something like spinning and you're pulling up and doing like sort of a kegel, a lot of places don't have pelvic floor therapy, like formal trained pelvic floor therapists. But if you can even get patients doing things like being aware of their pelvic floor, being able to control, like pulling up and pushing down, being able to pull their gut in and their stomach in, those are things that we in the office can even teach
Mhm.
without even really any experience. True pelvic floor therapists are miraculous and they have a lot of training. But I think that if you can even do anything to have people recognize that those muscles are there is helpful.
Yeah, most people don't know how to even like activate or deactivate their pelvic floor. And I'm going to correct you on Kegels just because I kind of hate Kegels from a generalist standpoint. I think that like saying that to someone and saying do Kegels, they don't know what that means. They think it's like squeeze, squeeze, and it's not. It's like I prefer the diaphragmatic breath that I was kind of showing one of those videos. It's you're kind of connecting to the pelvic floor from your rectum up through all the way up through your vaginal area, your urethra. It's kind of like a zipping, pulling up and in. Like one of the things that I read one time that stuck with me. I don't know why. It's like picking up a blueberry. You're kind of like doing that scoop mechanism. And then you're going to continue that up with your exhale and your breath, zipping up from the bottom with your core, kind of engaging and then learning how to reverse that. And I do have several videos for that on my social media. If there's someone that like, I do it now, but that would be weird. Like go back and watch me doing that and you can see my stomach kind of zip up and how that works. And those are absolutely the kind of things that we can teach in our office with just a little bit of, training and kind of watching and movement. And it's so valuable because even a non-pregnant, non-postpartum runner should know how to do that. And whatever exercise, you should know how to do that because how you engage your breath when you move will protect your or not protect your pelvic floor, your core long term. I have a male friend who was watching, he's a big supporter of what I do. And he was watching one of my videos and he was like, Morgan, he's like, I'm having coning. I haven't been training my core. And I noticed that I have coning when I do like powerlifting because he's a power lifter. And I was like, yes, men have pelvic floors, guys. Men have pelvic floors. Men have cores that are affected by things like diaphragmatic breath. They should know how to do that too. So this is not just a pregnancy thing or kind of, a little bit off topic, but yes, these are things we can teach in our office. I saw that question as well. If someone doesn't have access to pelvic floor PT, there are a ton of online pelvic floor physical therapists that are going like in-depth hardcore with teaching this if they're having specific issues. Myself, for the coaching component, I can do it anywhere. So if there's someone that wants, more advice on this and they're a runner, they can join one of my coaching cohorts. There are just make sure you're getting it from a reputable source is the bottom line. Like make sure it's either a trained pelvic floor physical therapist. It's a physician that is educated in this. Don't look at the fitfluencer that has abs and had a baby one time and is now sharing all this information. Because unfortunately, social media is wonderful for a lot of reasons, but also the marketing of it is pretty challenging for someone like us that is, giving really good, hopefully, advice that's based in science. But there are a ton of resources. And if that person has specific questions, if you want to email me or message me on Instagram, I can send you a couple links to some people that I like and or have worked with that I feel are giving good information. I'm happy to share.
So, and then there was another question that thought about kind of how we decrease the risk of diastasis. Is it okay to do crunches and core workouts? Is there harm in doing sit-ups and whatnot? Like, what is the truth behind how can you decrease the risk and what's dangerous to do in terms of core exercises?
Yeah, currently the data would say that we don't think that doing specific exercises is wrong. That's what I was going back to. There's no one exercise that's wrong. Doing crunches in pregnancy is not going to set you up for diastasis and like cause all of your problems. Now, doing crunches in pregnancy, when you're not doing them properly, you're holding your breath, you're coning, you're having issues, then that's going to be where the most problem happens. So all of the people that are advising on this now would say, there's no one thing like core that's going to cause your diastasis. Diastasis just happens. It has to happen. If you think about like, here's your rectus in the front, the linea albula in the middle. When you grow in the belly, the muscles can stretch to a certain point. They but they're going to reach their max kind of vertical stretch, and then has to start to kind of pull apart to fit a baby, or in some people's cases, like mine, two babies in there. The nature is very dynamic of those muscles, but it's only going to go so far before other tissues have to give way. The linea alba is like a rubber band. It's like kind of a dense tissue, but it's made to stretch probably for this exact reason, right? The muscle striations will only go so far. So this is a normal physiologic response. Having a diastasis doesn't mean you did something necessarily wrong in pregnancy. I did things right. I didn't cone. I was like very cautious of that, but I had twins and like I still have a diastasis. Like that's normal physiology. I think avoiding exercises that you can't do well with proper breath control, being mindful of what's happening with your breath, and that's something you need to practice in both pregnancy and postpartum is going to be the most protective thing that you can do. And then retraining your core in postpartum, not jumping ahead to, I want to go run without doing the rehab, doing the like painfully slow breath work that is required to retrain that core. And like I said, I'm 10 months postpartum. It takes a long, long time. I still do core exercises now, focusing at rehabbing and rebuilding. This isn't a 6-8 week thing. This isn't like a 6-week go exercise kind of thing. This is a much longer road. And being sure that you're very, very aware of your core, even if you're just planning to get pregnant someday, like that, it can just set you up for success in a so much better way. There's not going to say like, I'm not going to say, don't do an exercise, don't do this. It's just not the way it works currently with our research.
So a couple more questions. What about like round ligament pain and back pain? Is there anything other than just like putting on a pregnancy belt, maybe doing some osteopathic manipulations? Any advice for helping the
As you
common?
saw, back pain, 60% of pregnancy have some sort of back pain just related to the anatomic changes, the weight, the ligamentous instability that we develop. Being a very strong person before you get pregnant, the strong core protoplasm that is going to help you be able to stay as active as possible in your pregnancy is going to be key. The pregnancy belt can be very helpful for both back pain and round ligament pain because it's going to change the distribution of the weight. You have to wear it properly. Most people, if you look on Amazon to like buy one, the picture that they show, I hate because they're wearing it way too high. You actually want to wear it really low under the belly and around kind of like your SI joints posteriorly. And it needs to be cinched pretty snug. I'm not saying tight because tight, we could think about squeezing the belly, pressure phenomenon in the pelvic floor. Like we just went down that road. We're not going to do that again. But pretty snug because you're getting pelvic stability, you're getting round ligament kind of a lift by the body or by the belly, and also kind of decreasing that lordotic shape by kind of giving a lower lift. And again, I have a video about like where to wear it because it's just wrong so much on social media. Staying active is key. We don't make people that are not pregnant lay down with back pain and not move. We want our pregnant patients to be able to move as well, maintaining proper weight gain, strengthening exercises for their glutes. So I didn't allude to this in the talk because I seemed like a little bit more nuanced, but one of the areas affected most, in pregnancy and postpartum is our posterior chain. Think about how our bodies shift when we're pregnant. Everything kind of goes forward. And naturally, that's going to kind of de-emphasize gluteal recruitment. And so we end up with mom butt. You've probably seen that on social media or read about it, or you think, I had a baby and my butt just kind of like disappeared. It has to do with the decrease of activation of your gluteus because of the change in your pelvis, your anterior pelvic tilt, your belly, and then your body. So training your posterior chain in pregnancy can be helpful for back pain as well. Being sure to not just do, back exercises, but also glute hamstring and keeping that strong. And that'll protect you in the peripartum phase for postpartum as well, because if you are feeding, whether it be breastfeeding or bottle feeding a lot, you're sitting down a lot more because you're holding a newborn, you're going to be in that crunched over phase where we all get a lot of upper back and lower back pain. So strengthening exercises that can be done individually or again, rehab, pelvic floor, or regular PT is great for peripartum, pregnancy, postpartum, back pain and round ligament pain, the belt, and then, staying as active as possible before, during, and after, just like we talked about all the time. And someone said, is running safe for the baby? Yes, there's been no issues that running seems to be a problem for the baby. The baby is so well protected in there. As long as you're doing things like meeting caloric requirements, you're not overheating, you're getting hydration in, you're not going to like affect the baby. The baby is like super well protected. The impact itself, fine.
Well, thank you so much. This was such an awesome overview and a much, much underrepresented topic. I know that it's not even really that well represented on the testing. And hopefully as we move forward, we can continue to treat our pregnant and postpartum women more as athletes instead of as sickly, injured people that
We can do so much better. I know we can.
we can do better. That's right. So thank you for doing this. And I really appreciate everyone's questions and everything. And just best of luck to you, Morgan. It was great to see you, and hopefully everyone will have a great holiday and New Year's season.
Sounds good. Thank you all. For any questions, just send them my way. Happy to address them. If I didn't get to your question, just message me. Happy to help.
Throw your screen back up, your name information stuff.
Oh, good about to say, am I still screen sharing? What's happening?
You are.
All right. There we go. Everything is Sports Dr. Morgan, Sports Dr. Morgan, everywhere I am, TikTok, Instagram, social media, LinkedIn, everything is that. And I got lucky because, as Dr. Goldberg said, I actually got married now for almost 4 years ago, 5 years ago, I don't know. And I changed my last name. So I got lucky that I put it in Morgan, not my former last name. Otherwise you wouldn't know where I am.
Right? Exactly.
Thank you all.
Right.
It's been
Awesome.
awesome.
Keep doing good work. And yeah, that's that.
All right.